So, welcome to week 9. Today, we're going to be talking about Indigenous populations' health in regards to community nursing. So, like I mentioned, this week as well as next week, we're going to be referring to the health disparities among socially excluded, marginalized, and at-risk populations. So today we're going to specifically talk about the Indigenous population. So we'll have a little bit of an overview about the Indigenous community's experiences in relation to community health. We'll cover some concepts regarding Indigenous ways of knowing and being, and talk about the effects of colonization. So throughout the course so far, you've heard these terms of at-risk, marginalized, excluded communities, vulnerable communities, but what exactly does that mean? So this was something that was defined earlier in the semester, but just as a review, when we're talking about vulnerable populations, we're referring to specific at-risk populations and communities who are more susceptible to poor health because of socio-environmental factors. So the social determinants of health are something that do regularly come up in this course. So understanding that vulnerable populations are more susceptible because of these social determinants of health is key. And usually those within a population who tolerate a larger burden of illness. So the concept of the burden of illness was also discussed earlier on in the semester. So the burden is referring to the difference in the number of people that are affected between groups. And usually the larger the group, the larger the burden is. And this slide refers to some of the vulnerable populations. When we are referring to vulnerable populations, we're thinking about individuals with a lower socioeconomic status, the homeless community, immigrants and refugees, specifically Indigenous peoples. That's what our lecture is going to focus on today, as well as individuals with different abilities, older adults, even youth and children in disadvantaged conditions, individuals with low literacy skills, women, and individuals that identify as part of the LGBTQ plus community. And then, of course, within this list, there's also subgroups, right? And there's also links between all of these identities as well, right? Because it's all intersected. So for example, you could have someone that is a woman who identifies as part of the LGBTQ plus community and is also an immigrant, right? So a lot of these factors are not isolated. These identities are not isolated. They do intersect. So just a review of some of the key concepts, which will also come up in the lecture today. So when we talk about health disparities, this is talking about the variation in health services and in the health status among certain groups. So usually health disparities can show up as variations in health outcomes. They can show up as variations in access to care and even the quality of care. And usually there are socioeconomic factors that influence these health disparities. So it could be your race, your ethnicity, your gender, your disability, your geographic location. All of this and more can contribute to health disparities. So when you think about a health disparity, know that it's a measurable difference in the health status or the outcomes between groups. So for example, if we're looking at the Canadian population, research does tell us that Black Canadians have higher rates of hypertension compared to white Canadians. So that's an example of a health disparity. And of course, there can be so many factors like socioeconomic status, race, ethnicity, geographic location, that could be the reason for this particular health disparity. Then we have health inequities. So a health inequity is a type of health disparity. And a health inequity, the key way of remembering this is that it is something that is unjust and avoidable. So that's the key here. So these are differences in health that could be avoided if reasonable action was actually taken. So usually these avoidable and these unjust health disparities that are resulting in this health inequity are because of social, economic, cultural, and political factors that either directly or indirectly contribute to this health disparity. So an example is that Indigenous communities in Canada, they have higher rates of diabetes. And this is due to the lack of access to nutritious food, the lack of access to safe housing, as well as a lack of culturally appropriate healthcare. And all of this stems from colonization as well as systemic racism. So this is an example of a health inequity because these differences in health can actually be avoided. So that's the key term again, if reasonable action was taken, right? So resilience, on the other hand, is the ability of your client or the community that you're working with to cope with the hardships, so the reality of the hardship or the threat of the hardship. So even if you're thinking about your particular topic for your capstone, part of the needs assessment was to determine the barriers and the limitations, but also the strengths of this community, right? Because before you, as a community health nurse or a group of community health nurses came along and identified that X, Y, and Z are the health concerns that this community is facing, many of them already knew that, right? But they were still surviving. They may not have been thriving, but they were still doing something and they were still surviving before you came along. So what are those successful coping strategies that they have been utilizing up until this point? So usually we can also say that some communities, clients as well individually, they do need sometimes support to help decrease the challenges, and they need some support in enhancing their coping skills because that's going to provide them with a greater sense of personal autonomy. So this is something that we've also discussed throughout the course as well, is that when we're talking about community nursing, it's that upstream way of thinking. It's the bottom up approach, right? We're not employing that top down approach where we come in as community health nurses and we say we're the experts and we've done all this research and this is the problem with the community, so now this is what we're going to do to address it. We need to involve the community from the beginning. Yes, we may be the experts on certain things from maybe a research perspective, a community health lens, but the community is the expert on the community's needs. So involving them from the beginning is going to be very useful because you're going to get a better sense of understanding on what their challenges are, what their strengths are, what the limitations and the gaps are, which is then going to help you develop some sort of program to address one of these gaps and address one of these barriers. And maybe part of that program is to provide the community with enhanced coping skills. Maybe they need more education about this health disparity or this health challenge that they're facing, so that they can learn more about it, so that they're more informed, so that they can make informed choices in a more autonomous manner. So this image is kind of depicting the factors that predispose communities to vulnerabilities. So we have the determinants of health, we have health inequities, there's even age. So it's just like a visual representation of everything that we've spoken about so far. So next we'll talk specifically about Indigenous peoples in Canada. So in terms of Indigenous history, we're just going to go over some definitions. So the term Aboriginal is a colonial term that was created by the Canadian federal government, and it includes all First Nation, Métis, and Inuit peoples. When we're talking about colonial, this is referring to the power that's exerted by dominant culture of settlers over Indigenous peoples to maintain authority. And from a Canadian perspective, it is mostly the European settlers. So, of course, there's different countries that have been involved in the colonization, but there's a lot of British influence, Eurocentric approaches. Eurocentric was also in the lecture for last week. And the purpose of colonialism is really to replace the original population. It's to, throughout history, anytime we're talking about colonialism and colonization, the identity of the original population of that land, the purpose has been to wipe it out, to assimilate them into the Eurocentric model. When we're talking about Indigenous, we're referring to the original peoples of a land and their descendants. And this is a term that is used by the United Nations, and its aim is to uphold the human rights of Indigenous peoples. So when we're talking about the Indigenous term, we're referring to the First Nations, Inuit, and Métis people in Canada. And it has replaced the term Aboriginal, even though people still use the term Aboriginal. Indigenous is more reflective of the community. And the word Aboriginal, or the term rather Aboriginal, still does show up when we do acknowledge the rights of Indigenous peoples in the Constitution Act. And this term was assigned, which assigned the term Indian as the legal identification of those who were not Inuit or Métis. There's also another term called First Peoples. So this is a collective term that's used to refer to the original inhabitants of Canada. So when we are working with the Indigenous community, whenever it is possible, it is best to try and understand, describe, and relate to people through their specific and preferred ways of being identified. So as an example, if we're working with an Indigenous client or an Indigenous community, it's helpful to have a dialogue with them to understand, how do they identify? Because the term Indigenous, as we've just learned, it encompasses the First Nations as well as the Inuit, as well as the Métis peoples. However, these are very distinct groups. When we're talking about the Indigenous peoples, they're not a homogeneous group. There's a lot of variability within the different peoples that make up the Indigenous peoples of Canada. So understanding, how do they identify, right? So are they First Nations? Are they Inuit? Are they Métis? And then even then, we can even break them down into like more subcategories, right? So actually having a dialogue with your client and the community you're working with to understand, how do they identify? So for example, even in your textbook, there's a few examples. So Paul is a Moose Cree and Métis from Moose Factory Island in Ontario. Or Louise is a First Nation elder and a member of the Anishinaabe community, right? So we're trying to really understand the identity of the client and the community that we're working with. And that really comes from dialogue. So then we also have the Innu. They are part of the First Nation of Eastern Quebec as well as Southern Labrador. And the Inuit are actually not First Nation, but they're a distinct Indigenous cultural group originating from the Northwest Territories and Nunavut. So that's why I mentioned it's helpful to have a conversation with the Indigenous community that you are working with to really understand what their cultural identity is, because there is a lot of variation between the cultural groups. And since we are referring to the Inuit in this slide, there's actually a recent Netflix show that came out. It's a Canadian show, which is even like that much greater, that there's a Canadian show that's focusing on the Inuit community. I believe it's based in Nunavut, and it's called North of North. So the reviews on the show are really good, especially because they're saying it's Canadian, which is always great, and the actors that are used in the show, they are actually Inuit. So it's not that they're using actors that look like Indigenous peoples but truly don't identify with that identity. They've actually used representation from the community in the show. And another one of the reviews for the show is that they actually depict modern Inuit peoples in a respectful manner. Like there's even the way that they're dressing. It's not like you're stereotyping them. There's not a lot of the stereotypes that you would see maybe decades ago when you're talking about the Indigenous community. So if anyone's interested, it's called North of North. It's on Netflix, and yeah, it was a good show. I found it to be lighthearted. So this slide refers to some population statistics for the Indigenous population from 2021, which was the most recent stats that I could find. So the Indigenous population constitutes 5% of the total Canadian population. So there's approximately 1.8 million Indigenous peoples in Canada. And the First Nations is the largest group, approximately a little bit over 1 million. Then we have the Métis, which is the second largest group, around 624,000. And then the smallest group is the Inuit, around 70,500. So the Indigenous population in Canada is one of the largest among the countries that share a similar colonial history. So other countries like Australia and New Zealand also have Indigenous populations. They've also been colonized. But compared to these other countries, Canada has the largest Indigenous population. And the Indigenous population in Canada is relatively younger compared to the overall non-Indigenous population. So the Indigenous population was actually 8.2 years younger on average than the non-Indigenous Canadian population. So that being said, the health status of Indigenous people in Canada does fall below the general Canadian population. And we'll talk about some of these examples, but for example, Indigenous peoples do have a higher rate of chronic and infectious disease. And we'll talk a little bit about why that might be. And some of the general reasons why the Indigenous community might have an increased vulnerability could be because of biological susceptibility for certain medical conditions. It could be because of rural and remote lifestyle choices. So some Indigenous communities do prefer to live in rural and remote communities. That's how it was done traditionally. And you'll see that in that show, for example. We still have a lot of Inuit communities that live like very, very, very far north, where there is limited access to food. Housing is not always the most adequate. Grocery prices are skyrocketing. So these rural and remote lifestyles, which are part of their traditional culture, can also make them more vulnerable to certain medical conditions and socioeconomic factors because of the lack of support from the overall government. Some healthcare practices, as well as a lack of culturally appropriate health education programs, and even low socioeconomic status that can limit access to social determinants of health. These are the general reasons why the Indigenous population might be more vulnerable. There's also the forced loss of natural resources, which will make a little bit more sense when we talk a little bit about the history of colonization. But the loss of their land, which meant that there was a loss of a relationship to the actual land, that can also cause a disconnect with the way that they've traditionally gathered food, which can then affect the dietary changes, which can then affect, the way that they practice healing traditions. So the way that I try to explain it to my other section, when we think about the social determinants of health, it's a domino effect, right? They don't work in silos. All of the social determinants of health are really interconnected. And we'll see that coming up in one of the images soon. So this is the next couple of slides. When I post this, I will fix what is going on over here. But the next couple of slides are just a little bit of a snapshot of some of the history of the health status of the Indigenous peoples. So this is nowhere in as much detail as it should be in, but as an overview, in 1939, First Nations and Inuit people became the responsibility and the jurisdiction of the Canadian federal government under the Department of the Indian Affairs Act. So this meant that health, education, social services, this was controlled and organized for the Indigenous people by others. So that is why it's important to reclaim these health policies and these practices, and even the way that medicine is practiced, including traditional healing into these systems, because unfortunately for the Indigenous population, their health, their education, their social services, the access that they receive, that's all been controlled by non-Indigenous populations for so long. So in 1945, the services for First Nations and Inuit people were transferred to Health Canada. So the federal government is responsible for covering a number of health-related goods and services for the First Nations and the Inuit under something called the Non-Insured Health Benefit Program. I believe that comes up in the next couple of slides. And this program does not include health-related goods and services for the Métis. And there's many factors and many reasons for that. But one of the explanations is that for many years, neither the federal government or the provincial governments claimed responsibility for the Métis, which then led to a lack of access to programs and services. So of course, that's, I'm missing all the details and all of the historical context, but that's just one of the broad factors as to why it's not covered. The federal government and the First Nations and Inuit Health Branch, they provide health services for First Nation and Inuit people that are currently living on reserves. And First Nations are increasingly assuming local control through transfer of health services. So for acute care services, the First Nation healthcare systems interface with the Canadian healthcare system because hospitals are a provincial responsibility. And there are various types of funding arrangements that are available to First Nation groups seeking to administer their own community health programs. And health services offered to Indigenous peoples do range from primary health care to public health services. So there's primary healthcare services that are offered in isolated and remote communities, including emergency care. And then there's that program I'd mentioned, the non-insured health benefits. This does cover vision, dental, prescription medication, medical supplies, equipment, and short-term mental health crisis intervention as well. So now we'll talk a little bit about the consequences of colonization and the historical trauma that still continues to make the Indigenous population currently more susceptible and more vulnerable to certain health conditions. So, of course, this, like I mentioned, this is nowhere in detail, but this is a higher level overview. So, before the arrival of any European settlers in Canada, the Indigenous people lived and flourished in the land here, known as Turtle Island. And they were very innovative. They had their own education system, they had ways of gathering food, they had complex social and cultural governance strategies. Like I mentioned, the Indigenous peoples are not homogenous, there's a lot of variability. So they had ways of, managing nation to nation states. They had strategies for managing, preserving food, shelter, medicine, democracy, you name it. And the first known contact between the Indigenous peoples of Canada and Europeans was around the 10th century through the Vikings. And then that kind of started the concept or the practice of colonization. So when we're talking about colonialism, it's a policy about acquiring and maintaining colonies. So you have the wealthier power or the wealthier country that's going to control and exploit another society. So in the case of the Indigenous peoples in Canada, colonialism resulted in, the erosion of their social bonds. It resulted in the erosion of trust and even the dispossession of their original land. Then we had something called the residential schools. So these were these religious schools that were created and established by the federal government, and their goal was to assimilate the Indigenous community. So they really wanted to eradicate their language, their ceremonies, any sort of identity that they had. So in 1920, residential schools were actually made compulsory. And young children were literally taken from their homes, away from their families, stolen without any permission, just taken, placed in these residential school systems. And many of them never saw their families again. So you can imagine the intergenerational trauma that that experience would have had. Many of these Indigenous students in the residential schools faced atrocious sexual, physical, emotional, psychological abuse. And like I mentioned, some of them never even met their families again. Some of them even died on the properties of the residential schools. I even have a link here to a news article because I'm sure we're all aware a few years ago, information started to come out about some unidentified bodies that were found across various residential school properties out west. So I have an article that you can refer to. But like I mentioned, children were taken from their families. And there's something called the 60s scoop. So essentially in the 60s, even until the 80s, which is very scary because that was not that long ago, if you really think about it, children were still being taken away from their families. And it's called the 60s scoop because they were literally scooped up from their families and, placed in these residential schools. So when the children were taken away, they don't learn about their culture. They don't learn about their language. They weren't even allowed to wear their traditional clothes. They weren't allowed to speak their language. They weren't allowed to, practice like their healing traditions. They had to follow Christianity because many of these residential schools were Christian based as well. So their entire belief system was imposed on them. And like I said, a lot of abusive stories have come out about the residential schools as well. So this is going to create intergenerational trauma. And that is what we're referring to, or going to be referring to today, when we're thinking about the health disparities that the Indigenous community faces. So when I talk about intergenerational trauma, I'm really talking about trauma that's passed down from one generation to the next. So in Indigenous communities, this trauma really largely stems from colonization, right? So particularly the residential school system. So being removed from their families, losing their culture, losing their identity, not being able to practice their traditional ways, not being informed about their culture, their beliefs, not even being allowed to wear their own traditional clothing. Being removed from their land, there's a loss of culture, identity, language, everything. So even though these events happened many years ago, the pain, the grief, the disconnection, it still continues to affect the children and the grandchildren of survivors of these residential schools. So now we're going to talk a little bit about the Indigenous determinants of health. So while Canadians are considered among the healthiest people in the world, the health status of the Indigenous community in Canada, is lower than the rest of the Canadian population, and that's largely because of these dramatically different circumstances. So the Indigenous population does have a lot of health disparities virtually across all the health determinants, whether it's education, socioeconomic status, whatnot. They have disparities across all of them. So even though we have so the Public Health Agency, of Canada, they have the determinants of health that do affect all Canadians. Indigenous peoples organizations and their researchers have actually identified additional determinants of health that specifically affect the Indigenous people. And that's what we're going to talk about today. So, for example, regardless of Indigenous populations living in rural, urban, or remote locations across Canada, low socioeconomic status can be found in all of these populations. And First Nation communities have been reclaiming their own education, as well as developing their own culturally relevant curricula and training of Indigenous teachers. So as I previously mentioned, there has been a lot of reclaiming of their traditional practices or cultural beliefs, and really trying to reconcile with all the terrible things that have happened. And this is just another example of when you need to include the community because they are the expert, instead of imposing the top-down approach, which does not work. We need to get the community involved because they are the ones that know what works best for them. Another example is that on-reserve housing is often subpar by Canadian standards. So I'm sure we've seen and heard about, the pipeline concerns throughout the years, the lack of clean water, the lack of adequate and safe housing for the Indigenous populations on the reserves that they're living on. So these are real health disparities that are happening right now, literally in the country that we're living in. So it's really important for us as community nurses to know that there are a lot of systemic challenges that are currently happening as we speak. So this image here, I'm just gonna, so this tree diagram, it's a really powerful visual tool that explains the Indigenous social determinants of health because it shows the deeply rooted historical inaccuracies that are still affecting Indigenous Canadian health today. So we're going to start at the bottom over here. So here we have what we call the distal or the root determinants. So as we're looking at the tree, these are the things that we don't usually see, right? Because the roots of the tree are hidden. They're there, but we don't see them. So we often tend to forget about them, right? So these are the historical and the political forces that shape everything that's going on above here. So these roots are representing the long-standing trauma and the oppression that's been caused by colonization, right? So it's not always visible, but they fuel everything that's happening above here. So everything from mistrust in the system to addictions, to poverty, to poor health, it's all coming from these distal determinants, which includes the effects of colonization, systemic racism against the Indigenous community, social exclusion, repression of their self-determination. Then when we move up to the middle here, these are called the intermediate or the core determinants. So these are like, these are the systems and the structures that support or limit Indigenous health. So it's kind of like the tree trunk, right? It's the structure, it's the system that's holding the tree in place. So here we're looking at factors like we're looking at healthcare systems or the educational systems. So these factors affect access to health. It affects the trust in institutions. It affects community wellness. So for example, intergenerational trauma and poor access to culturally safe care come from these deeper systemic issues. Then at the top here, we have the surface determinants or the proximal determinants. So these are the visible and the immediate factors that affect their daily life and their health, right? So you can think of these as the tree, as the branches and the leaves of the tree, right? So this is usually the issues that you're gonna see as a nurse, as a community health nurse, that you see first when you're working with the Indigenous community. So you might see addiction issues, you might see no access to clean water, you might see a housing shortage, or even violence against Indigenous women. So these are the things that you can actually see. But in order to truly support the Indigenous community's healing, you have to look at the tree trunk, you have to look at the roots, because it's much more than just the surface level. It's why are the addictions issues happening? Why is there a housing shortage, right? So we're looking at the effects of the residential school system, right? People were ripped away from their families. That's going to cause a loss of identity. They experienced physical, sexual, psychological, verbal abuse. That's going to have an impact on their coping strategies. That's trauma. Maybe they're coping by using different substances. That's leading to their addiction. Maybe there's barriers to accessing health services, which is then another compounding factor. So the reason that we need to understand the layers of these Indigenous social determinants of health is because as nurses, we need to see beyond the symptoms, right? Beyond these leaves and beyond these branches that we're seeing, like addiction or housing issues or the violence against Indigenous women. We really have to look at the historical trauma underneath it all. And only then can we provide trauma-informed care, culturally responsive care, and even provide care in a non-judgmental manner. We also need to know about this stuff so that we can advocate for change, right? Not just for individual clients, but advocating for policy changes and systems changes that are going to impact the Indigenous community as a whole. And we also need to know, the different layers so that when we work in partnership with Indigenous communities, we can help promote self-determination and healing. One second. Okay. So trauma and injury, whether it's accidental or intentional, these are also related to physical environments, and they're high on the list of health issues faced by the Indigenous community. Healthy child development is an important health indicator. And for Indigenous populations, the birth rate is almost twice that of the general population. So as I mentioned, it's a very young population. And Indigenous peoples are represented in all occupations, including health, education, business, and the trades. And changes have been made to the social determinants of health to overcome the poverty and the third world conditions that are present in many First Nation communities. And social and community determinants of health, they affect the Indigenous population's health. So I've given some examples throughout the lecture, but another example here is that educational and employment opportunities are very limited in Inuit communities, which increases poverty. Yet the Inuit people pay 50% more for groceries than the residents of Southern Canada. So that just shows you that system, that oppression is built into the system. How are you supposed to pay 50% more for groceries if your educational opportunities are lower, which means your employment opportunities are that much lower, which means you don't have enough money to afford these expensive groceries. So they're stuck in that system of oppression that's been created. Another example is that there's a loss of the ancestral language. So like I mentioned in relation to the residential schools where they weren't allowed to speak their language. So a lot of it has been lost. So sometimes the grandchildren are not able to communicate with their grandparents because of that lack of awareness or lack of exposure to their native language, which is going to limit social support networks. So really the point of this slide is to show that domino effect. So in regards to culture, self-governance, and policies, the development of competent and culturally appropriate nursing care requires the community health nurse to keep in mind the historical, cultural, and changing clinical healthcare delivery system. So whether or not we are going to work specifically with the Indigenous community or not, as community health nurses, even nurses working in hospital settings, we do need to be aware of the cultural and the historical context of the Indigenous population in Canada, so that we are more equipped and to support their needs, to advocate for their needs. So Indigenous peoples continue to remain a distinct cultural segment of Canadian society. And there's many First Nation peoples that do hold traditional holistic health beliefs. So having that conversation, understanding from your client, how do they identify? Is there a particular cultural group from the Indigenous population that they identify with? How important is it for them to maintain their culture in their treatment plan, for example? Or within this program that you are trying to set up as community health nurses, right? So we need to be informed of the values and the norms that are shaping the particular Indigenous population that we're working with. We also need to be aware of competing policies and jurisdictions. So like I previously mentioned, the Métis are not included in a lot of these policies because there historically have been discrepancies on which level of government is providing them with support and services and who's taking responsibility. So we do need to be aware of what is going on from a political standpoint as well, because unfortunately health is politics, and politics does influence health and healthcare across Canada. So when it comes to traditional knowledge, in last week's lecture, I had mentioned the biocentric, no, I said that wrong. The Eurocentric model. Now I'm losing what it's called. Anyways, last week's lecture, I referred to the Eurocentric model of the healthcare system. So a lot of the healthcare systems here, in North America in general, they're based on Western Eurocentric values and beliefs, and oftentimes we don't incorporate a holistic perspective. As even in nursing, we try to be holistic, but the system in itself is built on Eurocentric values. So we don't sometimes realize that the holistic approach is missing. So for example, with traditional knowledge with Indigenous peoples, they really emphasize interconnectedness to all things, even with nature. So they use a framework, for example, that's called the medicine wheel, right? So this medicine wheel represents 4 quadrants of emotional, physical, mental, and spiritual aspects of your health and your wellness. And oftentimes that is missing from the Eurocentric model that we use to practice medicine and even nursing within a Canadian context, right? We don't tend to always focus on the preventative strategies or the root causes. We try to focus more on, this is the medical condition, now what is the treatment? Usually the treatment is some sort of surgery or some sort of medication that you have to take. We're missing that spiritual component a lot of the times. We're missing the, community connection. We're missing the root causes. We're missing why did this condition happen in the first place? Are there like imbalances in your life, including your psychosocial aspect? So being aware that there are other models, such as the medicine wheel, and having that conversation with the Indigenous community that you're working with. Is this something that they use often? Is this something that they want to implement in their healthcare treatment, in this program that we're trying to develop with them? So usually the medicine wheel philosophy is being taught by elders to the youth in Indigenous populations. And there's actually research where the medicine wheel philosophy has been adapted to certain health conditions. So for example, I'll give 2 examples. So if we're looking at addictions, the way that we would use the medicine wheel philosophy, so remember there's 4 components. So the physical could be the detoxification that the client has to go through. We can focus on their nutrition. Are they getting enough sleep? What is the quality of their sleep? Do they have access to do they have access to nutritious meals, a well-balanced diet? What about exercise? Then if we're looking at their emotional aspect, does this individual need counseling, or does the community as a whole need counseling that incorporates traditional healing strategies? Does this individual need to be reconnected with their family, or do they need access to support groups that are culturally responsive and linguistically appropriate? Mentally, does this program include goal setting, or is there a relapse prevention program? Mentally, we can also think about has this community been provided with information and education about addictions and why it happens and harm reduction? Do they have access to this information? And spiritually, you can incorporate maybe traditional healing ceremonies into addictions recovery, such as smudging or even reconnecting with elders or the creator. So that's just one example, and many of these examples that I gave for addictions recovery are used in many Indigenous healing lodges and treatment centers across Canada. And the next example I'll give you is for diabetes management. So like I said, there's other examples out there as well, but for the diabetes management example I'm going to give you, there's actually a program called Taking Care of Our Spirit, and it integrates the medicine wheel into diabetes education. So for the physical aspect, they're looking at healthy eating and blood sugar monitoring, as well as medication support. For emotional aspects, they're looking at, does this individual or does this community know how to cope with the stress and the stigma of having diabetes? Is there family support to help manage their diabetes, to help manage their nutrition? In terms of mental, is there a planning process for diabetes education, as well as the community's motivation to even engage in any change, and even with the emotional piece, and it could go into mental as well. Is there information and planning about the incorporation of traditional indigenous foods to help manage diabetes? And lastly, with spiritual, this program also incorporates prayer as well as traditional medicine and a balance with nature as part of their diabetes management program. So it's as I mentioned, it's called the Taking Care of Our Spirit program. So essentially the point here is to know that as community health nurses, we need to be aware of the traditional knowledge that the Indigenous community does bring. And oftentimes we do forget about it, but having that discussion, that dialogue with the community that you're working with is really key, because this is something that they've been using for centuries. And oftentimes we may not hold it in high regard because it's not something that we've been taught as part of our healthcare system. And we are missing a huge chunk of that holistic nursing piece by whether unintentionally or intentionally ignoring the use of traditional medicine. So this is a news article that I've included for you. It's from the CBC, and it's referring to Indigenous knowledge and how it can make healthcare more sustainable, especially in the North. It's an example of using sharing circles in the Indigenous elders in the Northwest Territories. So that's there for you to also take a look at. So in terms of cultural safety, as community health nurses, we do need to practice reflexivity. And there are a lot of culturally safe Indigenous training programs that have been developed in collaboration and even by Indigenous leaders and researchers to really help us truly understand the unique needs of the Indigenous community and how we can better work with them as healthcare professionals. And the health of many Indigenous communities is directly linked to their distinct culture and their worldview. And Indigenous communities do have the right to access without any discrimination to all social and health services. And our role is to support those rights and their health, as well as their well-being and access to these social and health services, so that they can get these needs with respect and dignity. So as community health nurses, we also have to engage in policy advocacy to really stop the colonial narrative, because it is, even though, like I mentioned, all this happened years ago, the effects are still visible today, and they're deeply rooted in our healthcare system. So as part of being nurses, being politically aware and advocating, even though it feels like you're going against the grain, that is what nursing ethics is all about. Even though something might seem very difficult, very challenging, we do need to advocate for it. We need to advocate for our vulnerable populations, including the Indigenous community, especially if we are in that position to help them bring their voices to these political parties and these political agendas. So this is the end of the lecture.